friends, welcome back to my new video in my channel, and this is a part 2 of my earlier video uh, on prognostification after Cpcr, which I had already discussed last time. And if you remember, this was the topic which I delivered during the Mahakritikon 2024 held in the beautiful city of Thane. So this is the continuation of the same talk, where in this particular video we'll start with talking on the biomarkers. We look upon a novel biomarker in the form of neuron-specific enolase, and this is a particular biomarker which is a protein found in primarily the neurons, and it is elevated in certain conditions which can have a signals towards the neurological damage which happens in various neurological conditions like stroke, traumatic brain injuries, and brain tumors. And the elevated NSE levels, which can serve as a marker for prognosis, suggests the potential long-term neurological complications, and of course it can have a bearing on the comprehensive assessment of the neurological damage. Another protein which we actually is mentioned in the literature is S100B protein, which is a calcium binding protein which is expressed in astrocytes, and it also helps in the assessment of TBI, especially we are talking about the traumatic brain injury, and it typically peaks within 12 to 24 hours post injury and will remain elevated for further few days. Here we need to have a few questions whether there are any extracerebral sources of the rays of this protein. We need multiple samples. It can actually indicate the injury to the brain and the functional component of that particular patient. Moving to the radiological investigations, and the first and the foremost and the easiest one is CT scans, which will help us to assess the structural damage, and of course the cerebral edemas, which can be detected quite early in a potentially life-threatening situations. So an average global GWR, which is below 1.14, or a GWR below 1.22 at the level of basal ganglia, which is seen on a CT performed within 1 hour after the ROSC, actually predicts a poor outcome with 100% specificity in few of the studies. So we are definitely looking at how sensitive and how specific a particular CT finding is. Moving on to MR, of course, it is a powerful imaging technique more than that of CT scan, and of course, it will help us to prognosticate, particularly detecting the subtle changes which happens in the brain tissues. And as we know, they can help us in identifying pathologies in specific brain conditions like tumors, the strokes, and infections, along with the other brain conditions. So you have something called as apparent diffusion coefficient, or ADC, and that is the coefficient which is used or utilized to read the patient's MRI after the injury. Talking about cardiac biomarkers, because we are talking about cardiac arrest, of course the troponins, especially the quantitative troponin I, the CPKMBs, and of course sometimes I'm sorry, the brain natriuretic peptides, which are also done. So they may actually play a crucial role in predicting the prognosis after the cardiac arrest. And there is of course a temporal pattern which is seen, and typically the troponins have a peak within 12 to 24 hours, and it can remain elevated for several other days after the initial rise. And the CPKMB, which again typically peaks around 20 to 24 hours, and then they gradually decline over the next 2 to 3 days. So, having kind of touched upon the major diagnostic and the prognostic modalities, we need to understand that it has to be a multimodal approach. So, the prognostification has to be a multimodal approach after the cardiac arrest, integrating the data from the various sources to provide a more accurate assessment of the patient's prognosis. So, starting with the neurological examination of the patient, then the clinical neurophysiology, the biochemical analysis, and of course the diagnostic imaging. So you have something like a scoring systems, and you have at steam style resuscitation registry, or there can be a Glasgow coma scale which we clinically use very often. uh, the Rancho Los Amigos scale is another scoring system which can be in the clinical use, and NIHS, which is another very standard scoring system as far as the stroke patient is concerned. So, the strategies which may improve our prognostification can be either a data-driven approaches, of course, the multidisciplinary collaborations, which will involve neurophysicians, the intensivist, the neurosurgeon, the orthopedicians, the cardiologists, and anyone who is involved in the patient care in the form of direct or the indirect involvement. And of course, there is continuing education, staying abreast or up to date with the latest researches and the advancements in the prognostification methods. So I would probably end this talk of the last two videos by this key takeaways, that the prognosis is crucial. The accurate prognosis after CPCR is very, very critical to guide the clinical decisions and manage the patients and the relatives' expectations. Time is of essence. So early prognostification is essential after, of course, after the first 72 hours. The multimodal approach which we just now discussed, and of course the scoring systems which will aid in going close to the ideal prognostification for the benefit of the patient. So that's all for now. I hope you enjoyed these two short videos, and I'll come with the next exciting videos in my next video. So that's all for now. Bye bye. Take care.